Today we have two speakers. Our first speaker is going to be Judy Harris, who's going to talk about 2021 E&M changes, and then Dr. Cayce Nawaf is going to be talking about adjuvant versus early salvage radiotherapy after radical prostatectomy. Excuse me, got to change my screen here. In high risk. I'd like to start by introducing Judy Harris, who launched the Yale School of Medicine's first medical billing compliance program and has been directing the program since 1997. She has successfully led the university through a 4-year settlement agreement with the Office of the Inspector General, and her work includes working closely with Medicare contractors, Centers for Medicare and Medicaid Services, and the Office of the Inspector General in areas of fraud and abuse and medical review in 16 states. So we'll turn this over now to Judy, if you want to share your screen.
So good morning, everybody. Today we're going to talk about how selecting the level of new and established ambulatory E&M codes is going to get easier in 2021. It's personally a treat for me in compliance to talk about something that's going to get easier instead of harder, because that doesn't happen often. And this is the first change to the E&M guidelines in 23 years. So I'm going to review what those changes are by the Centers for Medicare and Medicaid Services and the American Medical Association, what our strategy is to implement this, and what our expectations are for faculty training. So CMS has relaxed the documentation rules for the outpatient codes, and all payers will be following the rule. You will have to still wear 2 hats, however, because the previous rules are still going to be applicable if you render inpatient E&M services, see patients in the emergency department, consult, and the observation setting. So today, if you want to bill a level 4 new patient visit, you'd have to document a comprehensive history, a comprehensive exam, and moderate medical decision-making. So if you forgot to document a complete review of systems, you'd get downcoded to a level 2 visit. In 2021, that's not going to matter. As long as you've documented moderate medical decision-making, you can bill 99204, irregardless of what you documented for the history or exam components. So I'm hoping that this change may help eliminate some of the copy and paste that we currently see in the EMR. That would be a nice thing for everybody. So here's a side-by-side comparison of what's changing. Today we are stuck with the 3 key components: history, exam, and plan. In 2021, you're going to select the level of your E&M either by your medical decision-making or by time. Today, it's only your face-to-face time with the patient that counts. But in 2021, it's going to be the total time that you personally spent on that patient visit on the day of the encounter. Today, if you want to bill by time, you have to have documented over 50% of your visit was spent counseling or coordinating care. That's not required in 2021. 99201 new patient visit is deleted because the level of medical decision-making is straightforward, and that's the same as level 2 new patient visit. Today we have the table of risk. We have a medical decision-making table that to me is basically the same with a few tweaks to it.
Judy, before you move on, can I just emphasize a couple of things? Sure. So on your prior slide, the time, so that's the day of the visit starting at midnight. So if in your current practice right now, let's say there's some of us who pre-chart our patients the night before, that work is not reimbursed. But if you pre-chart, get up early and you pre-chart on the morning of the visit, that work is reimbursed. This includes things like all of the looking at films, reading through records. All of that stuff counts towards the time that you take to care for a patient. Epic has a clock in it that's gonna record how much time you spent on that in that patient's chart, but make sure obviously that that's time that you don't just have the chart open sitting there and you're doing something else. But if you keep track of time fastidiously on that 24 hours, you'll get paid for it.
Right. So I really like the fact that in 2021 we're going to have time ranges. Because, there was some ambiguity in the past with, well, it was a new patient and I saw them for 25 minutes. Can I bill up to the level 3? And the answer was no. Now we have time ranges, which is going to be nice. So again, as Dr. Kenny said, here are some examples of the of things that qualify for time. One of them that I really like is documenting information in the electronic medical record. You get credit for that. So I can't, I want to make sure that if you use the time that Epic is tracking for you as far as how long the patient's chart is open, you use that very cautiously, because you can be, you could maybe be doing activities, maybe you walk in the room and you're talking to the patient and you haven't even opened the chart yet. So the calculator can undercount your time. And if you don't close out of the patient's chart and you move into another patient room, it could overcount your time if you haven't closed the patient's chart. So it is a guide for you to help you know the total time you've spent. But again, I would just say use it with caution. And it can't be used for like the MA rooming the patient. If the resident's with the patient by themselves, you can't use that time. It's really only your time on the day of the encounter is counted toward the total time. If you are independently interpreting results and documenting that, you can include that in your time as long as you're not separately billing for that. Okay, so we're really left with the same three categories of medical decision making: the number and complexity of problems addressed. And addressed is really important. We see, problem lists carried over into patient notes, but if we're not seeing the problem being addressed, then you can't get credit for it. The words in red have been added to the definitions, so amount and complexity of data to be reviewed and analyzed. If you just say in your note, reviewed labs, that doesn't count because there's no analysis of what your review showed. And again, the complications and our morbidity or mortality of management. So again, we need to see that the problem was addressed and managed. And as Dr. Kenny said, Epic will have a calculator. It's not even in the test environment yet. I wish I could show it to you, but it's not there yet. But it will have a tab for medical decision making, which has check boxes. So if you've addressed 3 problems, you click in 3. If you've looked at, 3 different individual lab tests. So it's just check boxes, which I think will be a lot easier for everyone. And it will also have a tab for the time element. So what we did was we ran a report from 2019 to the present to see who bills these CPT codes that are impacted by the changes. And then we created an E&M video, which we assigned to these individuals in TMS. So you should have gotten an email from me and Dr. Capel on October 2nd if you bill these CPT codes, which I believe all of the faculty here do, saying that you need to go out and take the E&M video. At present, I don't have the exact number, or do I? Let's see. It looks like urology has about 29 faculty members that still have the requirement outstanding. So you need to go out and take the training. And if you haven't met your 2020 training, it will count toward your training. If you've already met 2020, we'll apply it to 2021. So we probably won't be updating TMS if you fall into the second bucket until we close out our 2020 training requirement. So you're likely not to see TMS updated till maybe mid-February. So here's the URL for the video, and we'd like everyone to complete it by December 31st because the changes are effective January 1 of 2021. So with that, does anybody have any questions? Okay.
So Judy,
Yeah.
Judy, I do have a question. With all of that, do you think this is more complex or more simple?
I definitely think it's more simple. And I love the fact that there's a calculator in there. So you're just checking some things and it will return the level for you. It's definitely easier. And it's really, to me, the way it should be. We've always stressed that your medical decision-making is the key to what level you should be billing. And total time is a bonus for us too.
And so what can you tell me about, like, so if I see a complicated patient, it's going to be a level 5 visit based on the complexity of the decision-making. Can you summarize what do I actually have to put in my note these days from a billing and compliance perspective?
I don't have the actual chart in front of me, but so I can't really answer that question. I'd have to have the criteria in front of me that's on the calculator, and unfortunately I don't have that with me at the moment.
Okay, but theoretically we could write the note may be less comprehensive about other things as long as we document the medical decision making and the complexity of it, or the time.
Right, that's really key. And I think that a lot of times, practitioners are over documenting in the history and the exam to meet those higher levels. And now you don't need to do that. It's really got to be in your plan. If somebody's got a new problem or a problem that's getting a lot worse, and you're spending more time thinking about that, then your plan is going to reflect that.
Judy,
this is Leslie Ricky. Can you hear me?
Yes.
I had a question about the medical decision-making calculator. What data is it pulling? Like, where does it find, is it just going into your assessment and plan and you have to have, I'm just trying to figure out how we can start getting in the habit now of making the notes so that the calculator finds it.
So the calculator the only thing that the calculator will look for is like tests that you've ordered, and it will count those for you on the day of the encounter. It's not going to look for how many problems you addressed. It's not going to be able to judge the risk of complications. So the only thing that's kind of automated in it is the orders, and that can actually be overwritten by you if you don't think it's correct. So it's really up to you to check the appropriate boxes. If you, like I say, if you address 3 problems that day, you'd put 3 in that criteria. It's the same 3 criteria, and you need to meet the level in 2 out of the 3.
Got it. Okay, thank you.
Judy,
This is Adam Hill. Can I ask you a point of clarification? Is there an actual clock that we can see? I know that Epic's always measured time, but is there an actual clock that shows us how long the visit's been?
On the tab that's the time tab in the calculator, at the bottom of the screen, I believe it is, it should show you how long you had the patient's chart open. Again, use that with caution.
Is that available now? Can we use
No.
Okay, that's something
No.
new. Okay.
Yes. Yep.
Judy, for the discussion, is it okay to use more of a style of bullets and try not to be so verbose, creating a whole dialogue, paragraphs? Would that be acceptable? Because it could still be complex, but having an abbreviated style of documenting.
Yes. Yep. There's no standard of how you have to document, whether it's in a SOAP format or whatever. As long as the information is getting across, that's fine.
Okay, thank you.
Yep. Okay. Anything else?
Hi, I have a question. I'm Ryan, one of the urology PAs. I was wondering, does this process also include like a new consult seen in the emergency room by APP, or is this just for outpatient clinic visits?
It's just for outpatient clinic visits, unfortunately. Great. I mean, I think that if this goes well, the AMA and CMS will roll it out to the other codes. But for right now, it's just for your ambulatory new and established patient visits.
Great, thank you.
Yep.
And Judy, is this for all payers or just some?
So it is for all payers. That's what I was told going, from our contracting area, that our contracts with like the commercial payers, they're bound to go by the latest CPT book, and so these changes will be in there in 2021. So this should be across the board by all payers.
Okay, any more questions before we go to Dr. Nawaf?
Judy, Tom Buckley, and it is just for, so a new patient in the office setting, you use this, but a new patient consult, you do not use this in the office setting.
That's correct. Yeah, and thanks for bringing that up. I get this question a lot about consultations. You're probably aware that Medicare stopped paying for them in 2010, and a lot of other payers followed, but we have 2 major payers that still do cover consults. So if you perform a consult, we want you to always bill a consult and let Epic take care of it on the back end. We will, cross it to the correct CPT code.
And there's no way for Epic. There's no way for Epic to tell us based on that patient's payer whether we can bill a consult or not. Because I mean, it's a different amount of work, and why go through all the work of a consult in terms of history and physical if you don't have to, if you don't know who's going to actually pay for it. So
because you should always document the service you perform. So if you're being asked for your advice and opinion in a consultation, then that's how you need to document it.
okay, but I mean, you know, but once again, I mean, it takes more work, and you're not going to get paid for it. I mean, it seems kind of silly to do it if you, I mean, to document all of that if you don't have to.
Yeah, again, you know, you have to document the service you perform. To do otherwise would be misrepresentation of your services. So you really do need to document what you've done.
So Judy and Tom, I'm sorry, this is Leslie Ricky, one more time. Just to clarify, everything we just talked about applies to new patients in the outpatient setting only, not new consults in the outpatient setting.
It applies to new and established patient visits in the outpatient setting. It doesn't apply to consultations in any setting.
Thank you, Judy.
Okay, all right, thank you. Have a good day.
Thank you. Okay, do we have Dr. Nawaf who could share his screen?
Great. Alrighty. So today we're going to talk about adjuvant versus early salvage radiotherapy. We're going to concentrate mostly on some three pretty big studies that have recently come out in Lancet, and we're going to briefly go over the data. So we're briefly going to discuss the definition of biochemical reoccurrence. We're going to discuss the newest clinical trials regarding adjuvant radiation versus salvage radiotherapy. So the reason why this is important is a third of patients treated with radical prostatectomy will have high-risk features. These high-risk features include extracapsular extension, positive margins, and seminal vesicle invasion. And 30 to 50% of these patients will have a biochemical reoccurrence. There's been 3 randomized trials in the past that have demonstrated a significant benefit of adjuvant post-prostatectomy radiotherapy for high-risk patients. So let's look at the guidelines. Guideline statement number 5 from the AUA and the ASTRA guidelines. Clinicians should define biochemical reoccurrence as a detectable or rising PSA value after surgery that is greater than or equal to 0.02 with a second confirmatory level of 0.02. This is a grade C. Great, alrighty. All right, so let's look at the guidelines. So the guideline statement number 5 from the AUA and ASTRA guidelines, clinicians should define biochemical reoccurrence as a detectable or rising PSA value after surgery that is greater than or equal to 0.2 with a second confirmatory level of 0.2. This is a grade C. In addition, patients should be informed that the effectiveness of radiotherapy for PSA reoccurrence is greatest when given at lower levels of PSA. So the sooner that we provide radiotherapy, the better that these patients do. So let's look at the alternative definitions of biochemical reoccurrence. This was a paper that a lot of our data is based off. This was the Stevenson and Scardino paper after Sloan Kettering. And what they did is it was a retrospective study where they looked at 3,000 patients after radical prostatectomy with a median follow-up of 49 months. And they basically assessed when the patients developed metastatic disease. And they found that the cutoff point to be able to provide adjuvant therapy is a PSA greater than or equal to 0.4 and rising. This was validated out of Cleveland Clinic by Jeff Carnes, where they essentially found the same thing, that the cutoff point is 0.4. And back to the guideline statement, the initial management of biochemical reoccurrence after radical prostatectomy. So patients should be informed that the development of a PSA reoccurrence after surgery is associated with a higher risk of development of metastatic prostate cancer or death from the disease. So if you have a biochemical reoccurrence, you're more likely to die from you're more likely to develop metastatic disease or death from prostate cancer. So we know that biochemical reoccurrence occurs in up to 35% of patients, but we do know that it is heterogeneous biology. So not every biochemical reoccurrence means that the patient is going to die from disease. It nearly always precedes systemic progression from prostate cancer, but it doesn't always result in systemic progression from prostate cancer. So you're never going to see, what it's saying is that if a patient does not have biochemical reoccurrence, it would be extremely rare for you to see any evidence of metastatic disease. However, just because you see metastatic disease does not mean that the patient is going to die from their metastatic disease or from their prostate cancer. What you have to weigh is, in men, especially greater than 60 years old, you have to weigh the competing risks and mortality. This was a pretty pivotal study about 20 years ago. This is the natural history of progression after PSA elevation following radical prostatectomy. It's called the Pound study. It was in JAMA in 1999. It was 304 men with biochemical reoccurrence after radical prostatectomy with a mean follow-up of 5.3 years. And 34% of these patients developed metastatic disease. There was a median of 8 years from biochemical recurrence to metastatic disease, and then a median of 5 years from metastatic disease to death. So essentially, what we surmise from this is that if you have biochemical recurrence, we can quote that you likely have 13 years before you will die from your prostate cancer. But again, you must consider the competing risks of mortality. So let's get into the 3 new studies that have just recently been released in The Lancet. These are 3 high-powered studies. So the take-home point is that the data from these 3 trials, as well as the artistic meta-analysis, which was a pre-planned meta-analysis to pool all of these studies together to see if we can come up with a stronger message, suggests that observation with early salvage radiotherapy should be the standard of care for men undergoing radical prostatectomy for localized or locally advanced prostate cancer. This is what the authors of the study have said in their conclusions. The authors of the studies explain that although prior clinical trials have shown a benefit of adjuvant radiotherapy versus observation in this population, the findings are difficult to interpret as a large proportion of the observed participants did not receive salvage radiotherapy, and thus the optimal timing of postoperative radiotherapy remains to be determined. So they basically said that patients in the past, that our studies are better because not everyone received salvage radiotherapy in the past. So let's look at each of the studies and look at the trial design and look at the results. So the first study was this was the RAVE study, so radiotherapy adjuvant versus early salvage. The eligibility is that you have one of the 3 of the risk factors following radical prostatectomy. So one of these high risk features of a positive margin, extraprostatic extension, or seminal vesicle invasion. You also had to have an undetectable PSA less than 0.1. They were then randomized according to their pre-op PSA, their margin positivity status, seminal vesicle invasion, Gleason score, institution, and then they received either adjuvant radiotherapy within 4 to 6 months of radical prostatectomy, or they went on to active surveillance. And when they saw a PSA rise greater than 0.1, they underwent early salvage radiotherapy. The radiotherapy was the same in both arms, and there was no ADT. So if early salvage radiotherapy is within 10% of adjuvant radiotherapy and biochemical control at 5 years, then salvage radiotherapy would be deemed non-inferior. That was the trial design. It was a non-inferior study. The target was 470 patients, but the trial closed after 333 patients were randomized with cutoff data analysis. Biochemical failure defined as PSA rise at 0.4 or higher post-radiotherapy. This is a study out of Australia and New Zealand between 2009 and 2015. What's highlighted here is that the patients are stratified very well in regards to their age, their preoperative PSA. Most of the patients had a Gleason score of 7. A smaller percentage had more high-risk Gleason scores of 8 or 9. The positive surgical margins were high in both of the population, as well as the seminal vesicle involvement was risk stratified pretty well. So 84 patients in the observation arm had a PSA rise to 0.2, triggering salvage radiotherapy, of whom 80 received salvage radiotherapy. So 50% had a rise, and they received salvage radiotherapy. And if you look at this chart, it's very similar. As you can see, the freedom from biochemical failure, it's very similar between the 2 groups. with a hazard ratio of almost 1. This has a median follow-up of number 1. If you look at the curve down here, they're very similar. So there is essentially no difference. So they even tried to stratify these according to the subgroups, and they found that no subgroups singly benefit from adjuvant radiotherapy. They found similar GI toxicity between both groups, but they found lower GU toxicity in the salvage group. So in the adjuvant group, for the GI toxicity, it was essentially the same. There was no significant difference. But in the adjuvant group for the GU toxicity, this included things like hematuria, urethral strictures, worsening lower urinary tract symptoms. There was a significant difference in the adjuvant group than the salvage group. This makes sense because if you're giving someone adjuvant therapy before they have complete regain of their urinary control, people think that that can lead to worsening long-term outcomes. So the take-home message of the study was early salvage radiotherapy results in similar biochemical control to early adjuvant radiotherapy. It spares approximately half of men from pelvic radiotherapy and is associated with significantly lower amounts of GU toxicity. Let's look at the second study. This is the RADICAL study. Again, all 3 of these studies were released around the same time. This was a randomized controlled phase 3 trial. Again, the eligibility showed that they had one of the following risk factors: pathological T3 or T4, Gleason score 7 to 10, positive margins, and a pre-op PSA greater than 9. They were again randomized and then to adjuvant radiotherapy or active surveillance with early salvage. The radiotherapy to the prostate bed, it was a non-randomized dose, either the 66 or 52. They said that that was institution dependent. In this study, they were allowed to have non-protocol hormone therapy, but this was tracked. So the aims of the study were to track biochemical progression-free survival, to track freedom from non-protocol hormone therapy, safety, and of course, patient-recorded outcomes. So this was 1,400 men were randomized. This was in Canada, Denmark, Ireland, and the UK between 2007 and 2016. The median follow-up is 4.9 years. Again, what's highlighted here is that essentially everything is really stratified accordingly. Same thing with patient's age, it's almost the same. The PSA at diagnosis, the presence of a positive margin. Most of the pathological T stage is 3A or 2. If we look at this curve, the 5-year biochemical free recurrence was essentially the same with a hazard ratio of almost 1. So 85% in the adjuvant versus 88% in the salvage. And it did show that in the adjuvant group, there was worsening urinary continence at 1 year and increased urethral strictures at 2 years. There was no difference in the GI long-term outcomes, but there was a difference in the GU outcomes. So the conclusions are, in the absence of any reliable evidence that adjuvant radiotherapy does more good than harm, observation with salvage treatment for PSA biochemical progression should be the current standard of care after radical prostatectomy. Let's look at the third study. Again, so this is a study where the eligibility was essentially the same. They randomized according to the same factors. The only main difference is that every patient received 6 months of androgen deprivation therapy in addition to randomization to adjuvant therapy versus active surveillance. The radiotherapy to the prostate bed was the same. All the patients received hormones times 6 months. The primary outcome was event-free survival. So it was assessed from the time from random assignment to the first documented event, which was either disease relapse, biochemical progression, or death. And the secondary outcomes were overall survival, metastasis-free survival, acute and late toxicities, and change in quality of life from baseline. This is a chart that's showing the 424 patients that were randomized across institutions in France between 2008 and 2016. What this is pointing out is, again, they're randomized very about the same according to age, Gleason score diagnosis, pathological T stage. Most of these patients are T3A or T3B. And again, not much difference between these curves. The 5-year event-free survival was 92% in the adjuvant radiotherapy group and 90% in the salvage radiotherapy group. In addition, you had more toxicities with the adjuvant group. You had acute GU toxicities were significantly higher in the adjuvant group and the late GU toxicities in the adjuvant group. One thing they pointed out was late erectile dysfunction was grade 2 or worse in 28% of the adjuvant group and only 8% of the salvage radiotherapy group. So they said that that was one of the main findings, that the patients with the adjuvant had much worse erectile dysfunction. So these authors concluded that these findings show that salvage radiotherapy could spare men from overtreatment and associated radiotherapy-induced toxic effects. This delayed approach will be preferred unless adjuvant radiotherapy was superior to salvage radiotherapy according to long-term oncological outcomes. So due to the fact that all 3 of these trials ended early without maximal accrual, there was a plan to do a meta-analysis by some big statistical group to essentially see if they can come up with more conclusions. So this is a planned meta-analysis that pooled the 3 studies. Again, this is just a table that's highlighting the main points of the study that we've already gone over. So it included data on all 2,100 participants of the 3 trials. There was no evidence of improved event-free survival with adjuvant versus early salvage radiotherapy. It was just an absolute difference of 1 percentage point in the 5-year event-free survival rate between the adjuvant and salvage radiotherapy groups at 89% and 88%. So both appeared to be safe treatments from a cancer control standpoint. The author conclusions that until data on long-term outcomes are available, early salvage treatment would seem the preferable treatment policy, as it offers the opportunity to spare many men radiotherapy and its associated side effects. This is the aggregated data plot where it showed the 2,000 patients from the 3 trials, and it showed that the hazard ratios are essentially the same, with no evidence that event-free survival improved with adjuvant versus early salvage therapy. So the conclusions, the data is promising regarding salvage radiotherapy versus adjuvant radiotherapy. We do need longer follow-up in the high-risk groups to evaluate metastasis-free survival. And until then, it is prudent to consider adjuvant radiotherapy in these patients, especially when you have to weigh the risks and benefits against other competing causes of mortality. That's it.
Great, thank you, Cayce. I just want to make 2 comments on sort of the historical data from Memorial and Hopkins. So when Stevenson wrote that paper, they looked at, and they sort of identified 0.4 as an optimal cutoff based on their retrospective data. But one of the other things that was not necessarily recommended, but that how that data is often interpreted, is there was a benefit in long-term survival and freedom from failure by administering radiation treatment at even lower PSA. So the lower the PSA at which salvage radiation or additional radiation was administered, the better the long-term survival. So many of us have interpreted that, not necessarily what the published findings stated with a cutoff of 0.4, but that the earlier you give salvage treatment or early salvage treatment, the better the outcomes will be. And secondarily, with the pound data, you mentioned it, but I just wanted to emphasize that that's the natural history. So that 13-year survival after biochemical recurrence was using a biochemical recurrence cutoff of 0.2, and that is and none of those men received any treatment until they had visible metastases on bone scan or CAT scan. So those 8 years of recurrence before metastasis, that's with no treatment. So that's just following their PSA and waiting for metastasis to occur. So I think this is a great summary of how we have, in this intermediate period here, have been probably over treating a lot of men with adjuvant radiation. So thanks a lot for presenting that, Cayce.
Cayce, this is Dan. I have a question. Maybe Preston could answer it as well. But the eligibility for these studies was a positive surgical margin, but it didn't really talk about what the Gleason score was at the margin or the size of the positive margin. Has anyone broken down, the risk of, metastatic disease or mortality based on the type of positive margin it is?
So the positive margin was always one of the factors that could make you eligible for the study. You could also have, a higher Gleason score of 7 to 10, or even just a higher preoperative PSA. But no, it didn't risk stratify the size of the positive margin. I think that'd be an interesting question, and especially the grade of disease at the positive margin.
All right, because a lot of, go on, Preston, I'm sorry.
I'd say these trials didn't evaluate that. That has been looked at in several other studies. I think Mike Whalen a few years ago gave a good talk on this, but the Gleason score at the margin definitely does matter. So if it is Gleason 6 at the margin, then the likelihood of biochemical recurrence is significantly lower than if it was higher grade. So if someone has a grade group 2 or higher, any component 4 or higher at the margin, their risk of recurrence is very high. And there is a benefit to radiation, but as evidenced by these studies, it probably still is early salvage rather than adjuvant. And in men with Gleason 6 at the margin, even if it's higher volume, higher volume is you're at a higher rate of recurrence than if it is microfocal. So less than 1 millimeter or 1 millimeter or less of Gleason 6, the rate of biochemical recurrence is actually the same as if the margin is negative. So I think for high volume surgeons who are trying to do a lot of nerve sparing, I personally will accept and sort of am happy to see a microscopic Gleason 6 because that means I spared as much margin as I could or as much nerve as I could without compromising the oncologic activity. Now, I don't ever want to have a positive margin, but it kind of shows you're right, a little tongue in cheek saying I'm happy. I mean, I never want to have a positive margin, but it means that it really was a maximal nerve sparing as well.
The numbers were too small, I think, to substratify by grade, but the vast majority of the patients were Gleason 7 and larger, so presumably almost all the margins are 7 or higher, which in terms of generalizability of the patients that are operated on, that's most of the patients that are operated on.
Nowadays, you're saying, Dinesh, or?
Yeah. I mean,
so I think that's in part true, but part of it also is for these positive margins. I mean, very often Gleason 6 is not visible in MRI, and we try to, or at least I try to avoid having a positive margin where I know there's higher grade disease, but very often there's MRI invisible and really undiagnosed or unknown low grade disease potentially at the opposite margin. So I would say the vast majority of the positive margins that I have are actually Gleason 6. There are very few that are high grade because I'm intentionally going wider where I know there's higher grade cancer.
Okay, are there any other questions? Okay.
Hey guys, this is Michael Lehman. I don't know if you can hear me, but Cayce, that was really excellent. A nice condensation of all of that new complex data. Just a quick sort of contextual note. We've looked at this also at the national level, and historically there has been very low adoption of adjuvant radiation, even in the era when the studies were positive. I don't know if you have any thoughts about how this is going to change management, or if it will. I think it certainly will move things in the direction of salvage therapy, but it's kind of worth noting that people don't really give adjuvant radiation unless, for the most part, unless there's very adverse features, seminal vesicle invasion, and a positive margin. But based on adverse pathology alone, Gleason 7 or 8, very little use of it.
I mean, just to comment further, I agree. I mean, I remember when we had Dr. Walsh come in and as visiting professor, and he discussed that as well. I think for many years, we recognized the side effects of the adjuvant radiation, and we only had 50% of people who really were going to benefit from it. Many of us were very hesitant to give that to everyone. So it's interesting that what you found there, Dr. Lietman, and sort of clarifies that the clinical practice was, we were waiting for these studies. We were hoping that these studies would validate our approach.
I mean, to me, I think one of the biggest differences with prostate cancer and some of our other cancers is we have an insanely sensitive way of detecting recurrence. And so obviously, even with, you know, salvage radiation therapy, there probably still is overtreatment. There are probably some people who are getting overtreated just because they're being salvaged for what may be a meaningless PSA elevation. And so I think of that as being like very different than like salvage therapy of someone who has radiographic evidence of recurrent kidney cancer, for instance, after a high-risk nephrectomy. And so, you know, I think prostate cancer, because we have PSA, is a very different animal.
That's a great point, Dr. Kenny. And one of the ways that we have available to try to further stratify those patients is now with genomic testing. So there is testing available for patients who are considered to have higher risk disease, and the Decipher genomic test is the one that does this. But really, anyone with any of these high risk features, positive margin, extracapsular extension, high grade disease, grade group 4 or higher, they can get that genomic test, and there is very good clinical data that shows some patients definitely benefit from, at the time it was adjuvant, but really it's probably early salvage radiation versus no radiation. And they really don't benefit from additional radiation and can be followed safely, as Dr. Kenny mentioned. So we can probably stratify some of those people, but yeah, this is very different than other cancers.
Okay, are there any other questions or comments? All right, I think this probably concludes our meeting today. So everyone have a good weekend.
Thank you, Casey.
Thank you.
Good job, Casey.
Nice job, Casey. Thanks, Tim.